Hi and welcome back. For today's video, I'm going to be talking all about common dermatological disorders that will tend to pop up on those nurse practitioner boards exams, but also happen to pop up in the office as well when working as an NP. So there is a lot to cover in this discussion today, but that's because there is a lot to know. I'll talk about viral exanthems, chronic inflammatory skin conditions, bacterial skin infections, fungal infections, animal and bug bites, and then skin cancer. At the end of the video, as always, I did include another dump sheet to help supplement your studying. There are 2 pages that are super helpful, and then they have tips for studying and for practice. Don't forget to leave me any questions that you might have, and then subscribe to this channel if you have found these videos helpful at all in your studies. And now on to derm. So the first exanthem that we're going to talk about is ROSEOLA infantum. And this syndrome is generally benign, self-limiting, and it most often occurs from the herpesvirus 6, and it affects young children, 90% of which are younger than 2 years old. So it typically starts with 3 to 5 days of a very high fever. It could be as high as 104 or even greater. And it resolves extremely quickly, and then a rash occurs. The rash typically starts on the neck and trunk, and then it spreads outwards up to the head and out to the limbs. The rash generally lasts about 2 days, and then it is described as an erythematous, generally non-pruritic or non-itchy, blanchable, macular or maculopapular rash. In instances where children were put on antibiotics for those viral symptoms that they were having, and then when they developed that sudden rash, it's been mistaken for a drug allergy when actually it was this rash that was occurring. And then at the bottom here, I have a little phrase that helped me to remember different things that differentiate roseola, and I picked out the S, and I said self-limiting before the 2nd year, starts on the stem and the stomach. So next up is PITYRIASIS rosea, and this is another viral exanthem that generally affects now adolescents and young adults, so a bit older population. Most of the individuals that have this will actually be asymptomatic aside from that pruritic rash. However, there are some that experience those prodromal symptoms of a headache, fatigue, then pharyngitis. Up to 90% of individuals with pityriasis rosea will experience first a herald patch, and this is a single, sharply demarcated pink or red lesion, generally about 2 to 5 centimeters, either located on the trunk or the neck. And this lesion will begin to have a central clearing and develop scales soon after its eruption. And then days to up to about 2 weeks later, that rash will spread with similar looking lesions throughout. And it will kind of go to the trunk and the extremities. Treatment is supportive, and topical corticosteroids can be used for itching. Little side note, topical corticosteroids, they are graded 1 through 7, 1 being the most potent. An example of that would be clobetasol. So the face and skin are at the largest risk for atrophying due to high dose corticosteroids, so we really want to avoid those in those areas. And then here at the bottom, I have another little phrase to help remember. Pityriasis is pruritic and starts with a patch. Most occurs post-puberty. Here we have scarlet fever, which is a complication of strep throat or pharyngitis caused by group A strep. So this rash is blanchable with papular elevations, and it typically begins in either the axillary or pelvic region. Other identifying symptoms would include circumoral pallor and then also a strawberry tongue. Here we have IMPETIGO, which is a bacterial skin infection, and it's divided into 3 different types, including bullous, non-bullous, and ecthyma. So non-bullous IMPETIGO is going to be the most common type, and this begins as papules that evolve into vesicles and then pustules. And these rapidly break down and cause a thick golden or quote-unquote honey-colored crust, and these lesions typically occur on either the face or the limbs. Bullous impetigo generally affects children, and this is where vesicles form a large fluid-filled bullae that erupts and again creates this light brown crusting. Ecthyma is more of a punched out appearance, and this is ulcers that extend all the way down into the dermis. it is recommended that you culture the pus and then begin treatment, however, empirically, either with oral or topical antibiotics. So if the impetigo is localized to one area, then topical mupirocin or Bactroban is first-line treatment. However, if there are multiple lesions or if eczema is present, then oral antibiotics are required. And the preferred oral antibiotics include cephalexin or Keflex or dicloxacillin. If MRSA is suspected, then Bactrim or doxycycline will be more of an appropriate treatment. Next up, we have erythema infectiosum, which, if you ask me, sounds like a Harry Potter spell. It is also referred to as Fifth's disease, and this is because it is number 5 of the 6 most common pediatric exanthems. So this viral exanthem normally affects school-aged children although adults can be affected as well, and it is caused by the parvovirus. Generally, this will present as a mild febrile illness with symptoms like coryza, headache, and diarrhea, followed by a rash 2 to 5 days later. And the rash is often described as a quote-unquote slapped cheek rash. And so the way that I remember this is it takes 5 fingers on a hand to slap a cheek, and then Fifth's disease. And then after this slapped cheek rash comes more of a lacy looking rash, and that appears on the trunk and the limbs. Here we have psoriasis, which is actually a common inflammatory skin disease, and it most often presents on the patient's scalp, knees, and elbows. And it's described as a sharply demarcated erythematous plaque that is covered in silvery scales. Another sign of psoriasis is going to be the Auspitz sign, and this is when bleeding occurs after a scale is peeled from the plaque. Topical corticosteroids for mild and limited disease are going to be the mainstay. The lower the strength that we can give that provides the patient the relief, the better. We can also add on vitamin D analogs as well, and I have a few listed there for examples. However, severe disease is going to require more systemic agents such as methotrexate, and that needs to be left to dermatology because it requires some very close monitoring. Also, UV light therapy is an alternative for treatment as well. So here we have RUBEOLA, also known as measles. And for me, I would get ROSEOLA and RUBEOLA mixed up. And so if you refer back in your studying on my slide before, I really focused on the S for remembering different traits for ROSEOLA. And here you'll notice that I focus on traits that begin with B to kind of separate them. Anyway, so let's get on to RUBEOLA. So this is a highly contagious virus, and this has symptoms like fever, fatigue, cough, coryza, conjunctivitis. And so what you need to remember is fever and the 3 C's. Fever and then cough, coryza, and conjunctivitis, that right there, followed by a rash, will give you the answer of measles or RUBEOLA. So another specific trait to RUBEOLA is that there are something called Koplik spots that can be seen, and these are small whitish, bluish, grayish dots that are seen in the mouth, and these occur about 48 hours before the rash actually appears. The rash itself is maculopapular, blanchable, and it typically begins on the face and then spreads cephalocaudally. Palms and soles are like almost never involved in this rash. A cough can persist up until 2 weeks after measles, so that's just important for patient education, and treatment is really supportive. Also, the literature does say that children with acute measles should be treated also with vitamin A, as a deficiency in vitamin A can actually delay recovery. Complications do occur in a small population, and that includes stuff like diarrhea, otitis media, respiratory tract infections, and even something as serious as encephalitis. Down here at the bottom is my little phrase to help remember RUBEOLA, and that is that RUBEOLA is a bad virus with bluish, whitish bumps on the buccal mucosa with a rash that begins at the ball cap, which is supposed to represent the head. Here we have cellulitis, and there are a couple different types that you need to know. Generally, this presents as erythematous, edematous, and warm to the touch. So there is non-purulent cellulitis, purulent cellulitis, and then erysipelas. Non-purulent cellulitis requires oral antibiotics or IV antibiotics, and the first line is going to be oral Keflex. IV therapy is going to be warranted if the patient has systemic signs of infection and is unresponsive to the oral antibiotics. If there is an abscess present, then first an IND or incision and drainage needs to be done, and then antibiotics. If purulence is seen, MRSA should be suspected, and the patient should be treated with something that can treat MRSA, for example, Bactrim. Erysipelas is another type of cellulitis, and this is a bright red, sharply demarcated and raised form of cellulitis. And there's a picture there on the right that is a really good image, I feel like. And this either occurs on the face or the legs. And then here for education, for patients with recurrent cellulitis on the legs and with current signs of PVD or peripheral vascular disease, compression therapy can help these patients to prevent these repeat cellulitis infections. So here we have lupus, or systemic lupus erythematous, and this is a chronic multi-system autoimmune disease that has a wide variety of effects on basically every organ of the body, and it is potentially fatal. So symptoms include things like fatigue, myalgias, arthralgias, fever during active disease, and then a unique butterfly rash that appears on the face. It spreads over the nose and the cheeks, but it avoids those nasolabial folds. So that picture shows it really well on how you don't see it in the nasolabial folds, but everywhere else is very bright red. Multiple systemic complications include renal involvement, clotting disorders, cardiac involvement, GI, pulmonary, their list goes on. So a definitive diagnosis is made when a biopsy is done on an involved organ and there is presence of anti-nuclear antibodies, or ANA. We need to be educating these patients on protecting themselves from the sun, as exposure to the UV rays can actually cause an exacerbation of their lupus. And also, number one, of course, we need to refer these patients to rheumatology. This slide is dedicated all to the fungal infections. There is a variety of them, and I don't know why, but initially I was overwhelmed by these, but I think this slide gives you all the information that you really need to know. So there's tinea capitis, which is a fungal infection on the scalp, and this requires an oral antifungal medication. And then just remember capitis for cap or head. Tinea corporis is a fungal infection on the trunk and requires topical antifungal treatment. Think corporis for your core or your trunk. Tinea curis is a fungal infection of the male genitalia only, requires a topical antifungal. Tinea pedis is a fungal infection of the foot and requires topical antifungal as well. And I think pedis for pedal or for foot. And then tinea unguium, which is a fungal infection of the nail, either the fingernail or the toenail. And this requires oral antifungals as well. And these actually take quite a while to work. 6 weeks for the fingernail, 8 weeks for the toenail. And that's because think about how hard the nails are. It's going to be really hard to absorb the medications and work on those areas, so it takes a while. And then I think of unguium for nail. I remember that unguium has the letter N in it and is the only fungal infection that has an N in the second word. So if you can remember that. Also, when I see the word unguium, I think of the word ugly, which makes me think of toenails, and that helped me to remember that. Topical meds will include the azoles, and then terbinafine is also a popular antifungal, which can be oral or topical. And then also nystatin, I wrote that on here. This is for candida only. And then also I wrote over here on the right, because it's important to remember which ones require oral antifungals and which ones require topical. And so when you're trying to remember, just remember that oral is required at the very top and the very bottom of all fungal infections. So at the very top at the scalp, and at the very bottom your toenails, also fingernails. And then those are your oral antifungals. Everywhere else, topical will be just fine. Here we have atopic dermatitis, also referred to as eczema, and this is a chronic inflammatory skin condition that is pruritic, and it generally affects children, although adults can be affected as well. It's also associated with an elevated IgE level and a personal or family history of atopy. So the appearance of the atopic dermatitis is a dry, erythematous, thickened leather-like skin or lichenification. Skin hydration for these patients is going to be imperative, and so emollients are going to be actually first line, and those should be used twice a day and then after bathing. For mild to moderate disease, emollients and then topical corticosteroids 5 or 6. Remember, 1 is the strongest corticosteroid, and 5, 6, 7 is the least strongest. Other interventions also on top of those corticosteroids and the emollients include things like phototherapy and then oral antihistamines. So next up is shingles or herpes zoster, and this is actually a reactivation of the chickenpox virus. So age is going to be the biggest risk factor for shingles, with the majority of cases occurring after 50 years old. So this is going to be contagious to anyone that has not had the varicella disease or chickenpox or did not have the vaccine, although it is no longer infectious after the lesions have crusted over. So the rash begins as an erythematous papules that generally follows a specific dermatome, typically on the thoracic or the lower back regions. Over several days, those papules evolve into vesicles or bullae, and then for the average healthy individual, the lesions will generally crust over in approximately 7 to 10 days. The most common complication with shingles is the postherpetic neuralgia, which it can occur up to 3 months after the development of shingles. So treatment for this is going to include things like gabapentin, pregabalin, or tricyclic antidepressants. For the treatment of the shingles, antivirals and analgesics are going to be the mainstay treatment there. Antivirals within 72 hours of onset in the uncomplicated case of shingles, and then only after 72 hours of onset if there are still new vesicles forming, showing that there's still active disease occurring. Otherwise, at that point, we wouldn't prescribe antivirals. And then examples of antivirals, of course, are acyclovir or valsiclovir. Herpes zoster ophthalmic is an eye emergency, and this is one of those things that we really need to be aware of in practice and is definitely likely to pop up on boards. And this begins with fever, headache, fatigue, and pain in whatever affected eye. The appearance of this shingles rash also occurs conjunctivitis, uveitis, keratitis. All these things are huge warning signs to us, and we need to emergently refer them to ophthalmology to preserve their eyesight. So next up is acne vulgaris, and there is a couple of classic features that you do need to know. Closed comedones are non-inflammatory, less than 5 millimeters, either skin-colored or white papules. Open comedones, those are also non-inflammatory and less than 5 millimeters. However, these are generally brown or black. Papulopustular acne is inflamed papules and pustules, still, however, normally less than 5 millimeters. And then there is nodular acne, which is inflamed and tender, large nodules and large papules. So topicals are going to be the preferred treatment for that mild to moderate acne vulgaris. And this includes topical retinoids, antimicrobials, and topical antibiotics. For mild comedonal acne, this could potentially improve with topical retinoids alone, and then there is an alternative listed there for you as well. And then for papulopustular acne, this is going to require the topical retinoids plus topical antimicrobials. For the more moderate to severe acne vulgaris, topical and systemic drugs are going to be the mainstay of treatment there. Common oral therapies are going to include things like tetracyclines, oral contraceptives, oral spironolactone, and then oral Accutane. So caution with these drugs, though, as not one of them are going to be safe in pregnancy. So next up, we have the treatment plan for cat, dog, or human bite. Generally, for all of these, we're going to clean that wound very thoroughly, irrigate it. Most of the time, we're going to do prophylactic antibiotics, and this is amoxicillin with clavulanate for 3 to 5 days, also known as Augmentin. There are a few alternatives listed there for you as well. And then, of course, tetanus and rabies prophylaxis if those are indicated. And then important to note, too, that we're not going to close these wounds. We'll let them go ahead and heal on their own unless it is on the face. Next up, we have a slide dedicated to different bug bites, including the tick and the brown recluse. I'll be honest, bugs definitely give me the heebie-jeebies, but this is a hot topic. You need to know it for your boards and obviously for practice. So tick bites, this can cause either Lyme disease or Rocky Mountain spotted fever. So it's definitely a serious thing. Lyme disease is broken into 3 phases, and generally that first phase has something called the erythema migrans, which is this picture you see here on the right hand side, and that is the rash that develops at the bite site. And this is a great opportunity for us to pick up on this and stop this disease in its tracks, because it can definitely go on to cause a lot of havoc for the person. Treatment is going to be doxycycline, and there is a backup included there for you. Rocky Mountain Spotted Fever, this is also a tick-borne disease, like I said, and it's caused by the gram-negative bacteria Rickettsia. So it begins with more generalized symptoms of fever, fatigue, headache, arthralgias, and then a rash develops typically between day 3 and 5 of the infection. It is blanchable, erythematous, with macules approximately 1 to 4 millimeters in size, and they generally begin on the ankles and the wrists. And later on in the disease can actually spread to the palms and the soles. Typically, absolutely, we're going to treat these patients empirically, again, within hopefully 5 days of those first symptoms, and the treatment for this as well is going to be the doxycycline. And diagnosis is confirmed with serologic testing. So for the brown recluse bite, first, you need to know where these are typically found and who's going to be at a bigger risk. They generally like to hide in dark areas such as basements and attics. This whole bit gave me the heaves for sure. So initially the bite is going to be painless. However, within hours after the bite, the patient can actually become in severe pain. The site is erythematous. It appears as either a red plaque or papule. And then some of these patients will actually go on to form an eschar, which will eventually ulcerate. And then 10% even develop necrotic tissue there at the site. Also, there's going to be systemic symptoms, and those can include fever, nausea, vomiting, myalgias, and fatigue. Here we have another slide dedicated all to bugs. Unfortunately, there are some more that tend to pop up though. And this is scabies, lice, and pinworms. So the first one that I have here is pinworms, and this causes perianal itching. The treatment for that is going to be oral mebendazole, also known as Vermax, a little easier to say, and this is a single dose. And then there's hair lice, which is also highly pyretic. Important to note, the CDC says that if nits are more than a 1/4 inch away from the scalp, they are almost always non-viable and they don't require treatment. However, if they do require treatment, then topical permethrin seems to be effective. And then lastly here is scabies, which is an infestation of a mite. Symptoms include intense itching again that worsens at night. Common sites include fingers, wrists, the axillary area, and genitalia. And then treatment for this is also topical permethrin. The last topic is going to be skin cancer, and there's definitely a lot of important points here to digest as well. So the first lesion is actinic keratosis, and these lesions arise from atypical skin cells, and they generally appear on the face and those sun-exposed areas. These lesions are particularly concerning because most squamous cell cancers actually arise from these lesions. These are typically reddened macules or papules or plaques, and they have a scaly appearance. So first line treatment for these is actually going to be removing them, and that's either with cryotherapy or surgery. The next is basal cell cancer. 70% of those appear on the face, and these are described as pearly and translucent in appearance, and they often report telangiectasia as well. And then squamous cell, these lesions can appear anywhere on the skin, including head, neck, trunk, limbs, everywhere. So fair-skinned individuals, they usually will present with squamous cell cancer on areas of the body that are exposed to the sun. However, individuals with a darker pigment, they usually will present with the squamous cell lesions on less exposed areas, like the legs or the pelvic area. So squamous cell carcinoma lesions, they come in a variety. They include papules, plaques, nodules. They could be smooth in texture or hyperkeratotic. Generally, they are well demarcated, though, and erythematous. And this is really kind of ties into the importance of that ABCDE rule, which I'm almost at. So melanoma is going to be the most serious of the skin cancers. 70% of melanoma presents as macules or thin plaques with irregular borders that come in various colors, typically a darker red, brown, black shade. And then lastly is that ABCDE rule that kind of helps tie everything together and helps us to know what to look for when lesions are concerning or not. A for asymmetry, B for border irregularities, C color variation, diameter for D, which is greater than 6 millimeters, E evolves in its characteristics. First example, it changes in size, color, shape, etc. All of those are warning signs and warrant a referral. This last slide here is just some images of the lesions that come with skin cancer, also the actinic keratosis. I'm a very visual learner, as you can probably tell. I like colors and pictures. It helps me to learn, so hopefully it helps you. And all of these are pretty good pictures showing all of their characteristics, I feel like. As always, at the end here are the dump sheets, everything that you really need to know before going into your board's exam. And then also just really important clinical pearls, of course, for going into practice. So this is slide number 1 of 2. I'll show the second one here in a second. I'll give you a second to glance it over, take a screenshot if you want, and save it and study over it. But hopefully it's helpful for you. I really use these a lot in my studies for boards. And here is that second dump sheet. Lots more very important information on it. I will say the only thing that I did not include on these dump sheets would be the fungal infections. There was a slide that had everything on there that you would need to know, so if you want to go back in the PowerPoint and look at it. But everything else should be on these dump sheets for you as far as clinical pearls and just key points. Again, as always, go ahead, screenshot, print it, do whatever you need to do. And then while I'm here, I'll also mention that in the description box, I will go ahead and link the Facebook group that I created, the new NP group, and there I actually share PDFs of these documents that are more printer friendly. So if you want to go ahead and join that Facebook group, you can find the PDFs there. All right, and we finally made it to the reference sheet here. Everything was from up to date. I listed all of the sources there for you. If you made it this far, congratulations. I know that was a huge long PowerPoint, but there was a lot to cover. Don't forget to leave me any comments, questions, requests, feedback, anything like that in the comment section below. And also don't forget to subscribe to this channel if you're finding any of this helpful studying for your board's prep. As always, I wish you the best of luck in your studies, and I will talk to you very soon.